Welcome to Essential Neuroanatomy Review, Lesion Localization in Neurology, Brainstem, Cerebellum, and Eye Movements. This is David Lee Gordon, Professor of Neurology. For Essential Neuroanatomy Review, the learning objective is to localize a lesion in the nervous system based on clinical presentation, that is to say, the history and examination. The brainstem is the funnel or connector between the cerebrum and the spinal cord. As such, long tracts run through it, both motor long tracts going from the cortex down to the spinal cord, and long tracts going up, sensory pathways from the spinal cord up through the brainstem to the cortex. The brainstem itself is quite small. The width is about that of a pen or pencil, and so bilateral lesions are fairly common when they occur. When there are lesions in the brainstem, therefore, the lesions tend to be bilateral. The symptoms and signs tend to be bilateral, such as quadriparesis and sensory loss in all four limbs. Now, you can also get quadriparesis and sensory loss from the cervical spine, but when you have quadriparesis or sensory loss in all four limbs and also have face or head involvement, like cranial nerve involvement, like eye movement abnormalities or vertigo, etc., then it's likely a bilateral brainstem lesion. On the other hand, it is possible to get a lesion on one side of the brainstem, and unilateral brainstem lesions tend to give crossed signs. What is a crossed sign? This refers to situations in which one side of the face is abnormal and the other side of the body is abnormal. In general, cranial nerve lesions are ipsilateral. Cranial nerves, rather, stay ipsilateral in the brainstem. They come from the brainstem and serve the ipsilateral face, etc. Whereas the long tracts in the brainstem tend to be contralateral to the body that they serve. So a lesion on one side of the brainstem would give you ipsilateral face findings and contralateral body findings. That's called a crossed sign. There are two main types of focal deficits in the brainstem: primitive center deficits and cranial nerve deficits. To recall, there are three components of the brainstem. More rostrally is the midbrain, then the pons, which is the fatter, wider middle section, the bridge to the medulla, which is narrower and more caudal, running into the spinal cord. The most prominent of the primitive centers in the brainstem is the ARAS, ascending reticular activating system, in the dorsal, midbrain, and upper pons. Lesions in the ARAS cause depressed consciousness. It is the consciousness center. In the dorsal medulla is the area called the area postrema. It forms the floor of the inferior part of the fourth ventricle, and it is the nausea and vomiting center. When patients have hydrocephalus and the fourth ventricle enlarges, it presses on that area in the dorsal medulla and causes nausea and vomiting. In the medulla is the cardiorespiratory center, and lesions there can cause hiccups or abnormal respirations. In terms of cranial nerve deficits, the cranial nerves 3, 4, and 6 involve eye movements, and 3 and 4 are the most rostral in the midbrain. Their dysfunction can cause double vision, especially vertical diplopia, 3 and 4, in which the images are little one higher than the other. That's the exam find. That's the history, I should say. The exam finding that goes along with diplopia is dysconjugate gaze. The eyes aren't moving together. This would be a midbrain problem. The sixth nerve nucleus is integrated into the horizontal gaze center in the mid-pons. So lesions that involve the nucleus of 6 have the same effect as involving a horizontal gaze center, and that is a gaze palsy, a horizontal gaze palsy. Lesions involving the cranial nerve 7 will give you a complete facial weakness. That's the lower motor neuron facial weakness ipsilaterally, and the cranial nerve 7 is in the mid pons. Cranial nerve 8 is in that low pons, high medulla area, and its dysfunction can cause vertigo and tinnitus, ringing in the ears. And involvement of cranial nerves 7, 9, and 10, the cranial nerves that supply the palate and a lot of the muscles of swallowing and speaking, can give you dysarthria, slurred speech, from motor weakness of mouth muscles, and dysphagia, trouble swallowing. A very important and common brainstem syndrome is the ischemic stroke syndrome called lateral medullary syndrome, or Wallenberg syndrome. This syndrome occurs when there is an infarction in the posterior inferior cerebellar artery, or pica territory. It's usually due to embolism, a traveling blood clot coming from either the more proximal vertebral artery or the heart, as a cardioembolism. The slide here shows on MRI DWI an acute infarction in the right lateral medulla, and also shows normal anatomy once again on the MR angiography, showing where the pica does come off the vertebral there. The most important thing to remember here is that these folks have contralateral, or I should say cross signs, where you have face pinprick on the ipsilateral side and contralateral body pinprick loss. That is a major distinguishing factor. Major. Now, the problem with these folks is no one's going to come in saying, I've got pinprick loss on one side and my face on the other side of my body. They're actually going to come in with symptoms of vertigo, the sense that the world is moving or spinning or rocking, nausea, maybe some swallowing problems, dysphagia and sleep-speaking problems, dysarthria, hoarseness, hiccups, etc. So it is common for doctors who do not understand neurology well to not recognize that someone who comes in with vertigo and nausea and maybe vomiting is having actually a lateral medullary stroke. One must actually examine the patient and look for crossed sensory loss to pinprick, or ipsilateral Horner syndrome, which occurs in this syndrome, or ipsilateral hemiataxia. Simply look at the patient for one eye being more narrowed, that's the Horner syndrome, that same side having ataxia on the limbs, and also pinprick loss or temperature loss on that side of the face and opposite body. You must recognize those things and find them and determine that someone had a stroke in the pica territory. This is a very important syndrome that everybody must recognize. It's quite common. Lesions in the cerebellum cause limb and or gait ataxia. Ataxia is abnormal coordination of a limb, trunk, or gait. A cerebellar hemisphere lesion, that's the most common kind of cerebellar lesion, causes ipsilateral limb ataxia with ipsilateral veering and falls. The cerebellar midline lesions, however, cause truncal or gait ataxia, imbalance with wide base gait and falling to no side in particular. Note that the cerebellum controls the same side of the body because the cerebral cortex controls the opposite side of the cerebrum. As you can see from this picture here on this slide, the inferior cerebellar peduncle is coming in the green, the supracerebellar from the spinal cord to the cerebellum. Then you've got the superior cerebellar peduncle in the pink there going to the contralateral brainstem, the midbrain, that red nucleus, then going up through the thalamus up to the frontoparietal cortices. And then you've got control from the brain to the cerebellum through the middle cerebellar peduncle. The yellow fibers, frontopontocerebellar fibers, are in yellow, and they go into the cerebellum via the middle cerebellar peduncle. We shall now discuss eye movements, and the term gaze refers to yoked eye movements, two eyes moving together. Normal gaze is conjugate, meaning conjoined. The eyes are conjoined in their movements so that both eyes can see the same image. And gaze can be referred to as vertical or horizontal. Vertical gaze consists of up gaze and down gaze, and horizontal gaze, right gaze and left gaze. Vertical gaze abnormalities are not common, and we will not discuss them further in this presentation. Horizontal gaze abnormalities, however, are common, and they are termed gaze deviations. And a gaze deviation may be due to either gaze preference or gaze palsy. Gaze preference is inability to move the eyes volitionally in the horizontal direction, and gaze palsies are complete inability to move the eyes in the horizontal direction. Interestingly enough, gaze deviations are asymptomatic to the patient, since the gaze remains conjugate. Both eyes are still seeing the same image, and the patient doesn't actually notice the deviation. Diplopia means double vision, in which a patient sees two items instead of one. Neurologic diplopia, that is to say, double vision due to a neurologic dysfunction, is a motor problem with sensory symptoms. Neurologic diplopia is always due to extraocular muscle weakness. And on exam, the patient has what we call dysconjugate gaze, DYS abnormal, conjugate conjoined, so not conjoined eyes on exam. The eyes aren't looking at the same thing. And neurologic diplopia is always binocular, which means the double vision only occurs when both eyes are open. Closing either eye resolves the double vision. You only see double because each eye is looking at different things. If you close one eye, you don't see two things. One can determine the exact muscle that is weak by asking the patient in which direction the double vision is worse. The images are farther apart. If you look to the right and the images are farther apart, you look to the left and you don't actually have double vision, then you know the problem must be with the muscles that make you look to the right. This is how we figure this out. The two kinds of binocular diplopia are horizontal, in which the images are exactly side by side at the same height, and vertical, in which one image is slightly higher than the other. There's no such thing as vertical diplopia with one on top of the other. That doesn't exist. There's always some element of a horizontal component to the diplopia. But if there's any vertical component whatsoever, we call it vertical diplopia, not horizontal diplopia. Now, strabismus, which is in which a patient has dysconjugate gaze from either birth, congenitally, or early in life, does not cause double vision. Why not? Because over time, the brain gets tired of looking at the two images and it ends up suppressing one of the images. So people who get dysconjugate gaze or strabismus at a young age don't have double vision moving forward. Monocular diplopia, which is when you have double vision with one eye open, is not neurologic. It's an ophthalmologic problem usually an eye issue, but it's never neurologic. Neurologic diplopia is always binocular and occurs due to extraocular muscle weakness. There are 6 cardinal positions of gaze, not 4 as one might suspect from up, down, left, right. And that's because in terms of looking up and down, there are 2 muscles that help you look up in each eye and 2 muscles that help you look down in each eye. The lateral gaze is the easiest to discuss, so let's start there. The lateral rectus abducts the eye, makes the eye look out, as you can see in this depiction. The medial rectus makes you look in, adducts the eye. The lateral rectus is cranial nerve 6, and the medial rectus is cranial nerve 3. Looking down below here at the different right gaze and left gaze depictions, in the right gaze, it would be then the right lateral rectus and left medial rectus and make you look to the right. And left gaze would be the left lateral rectus and right medial rectus, which makes you look to the left. The up gaze is more complicated. Looking up and out, up and when you're looking out, is the superior rectus, making you look up when you're looking in would be the inferior oblique. And so the right up gaze would be right superior rectus and left inferior oblique. The best way to remember this in terms of up gaze and down gaze is the rectus. The word rectus means straight. The superior rectus is the main muscle to think about. When someone looks right and up, the superior rectus makes you look up when looking out. And then on the other eye, just go opposite side but oblique, so inferior oblique. So the right superior rectus and left inferior oblique make you look up and out. Likewise, looking left up gaze would be left superior rectus, start with the superior rectus, and right inferior oblique. Following this pattern, the right down gaze will be right inferior rectus and left superior oblique. And looking left down gaze, left inferior rectus, and right superior oblique. The superior rectus, inferior rectus are both cranial nerve 3, as is the inferior oblique. However, the superior oblique is cranial nerve 4. Let's look at the horizontal gaze neuroanatomy. So recall the frontal eye field in the frontal lobe is the upper motor neuron control center. It controls only volitional gaze, and it controls gaze to the contralateral direction. It does so by stimulating the horizontal gaze center in the contralateral pons. The horizontal gaze center is the lower motor neuron control center in the pons. It consists of both the paramedian pontine reticular formation, PPRF, and the cranial nerve 6 nucleus. They are embedded, basically they work together. And the horizontal gaze center controls gaze to the ipsilateral direction by stimulating the ipsilateral cranial nerve 6, which makes the lateral rectus contract, and then via this little highway going backwards called the MLF, the medial longitudinal fasciculus, which goes to the contralateral from the horizontal gaze center, contralateral medial rectus subnucleus in cranial nerve 3. So it makes the medial rectus go in the same direction that the lateral rectus is going. Looking at horizontal gaze pathology or deviation, recall that gaze deviation can be due to either gaze preference or palsy. So specifically in this case, we'll look at right gaze deviation. And again, right gaze deviation due to right gaze preference or left gaze palsy. Now that may seem confusing. Right gaze preference equals left gaze palsy. Let's explain. The right cerebrum, right frontal lobe, right frontal eye field, makes you look left. So if it is damaged, if the right frontal lobe is damaged, you can't look left, you look right, you look to the right. Now this is often described in literature as looking to the lesion. But please recall, looking to the lesion only refers to the frontal lobe lesions. It actually does not pertain to the pontine problem, which we'll talk about in a second. The way you tell it's a preference and not a palsy, as we've described before, is the doll's eye maneuver. In the doll's eye maneuver, the eyes, if a normal person has normal doll's eye maneuver, then the eyes can look in both directions when you swing the head around. But if, on the other hand, when you do that, it does not work, then it might not be a preference, it might be a palsy. Let's look at the palsy sequence. So if you have a lesion in the left pons, you can't look left. So we call that a left gaze palsy. You can't look left. We call it by the negative left gaze palsy. And on doll's eye, the eyes will not swing to the left. So one way to remember this is a right gaze preference is in the right frontal lobe, whereas a left gaze palsy is a left pontine lesion. Right gaze preference, right frontal, left gaze palsy, left pontine. In both cases, it appears initially as a right gaze deviation. Cranial nerve 6 or abducens nerve palsy is one of the most common cranial nerve palsies. The symptom is binocular horizontal diplopia, worse in one direction, specifically the direction on the side of the cranial nerve 6 palsy, and double vision that is worse with far vision as opposed to near vision. And there are some specific anatomical reasons why cranial nerve 6 palsy is so common. Let's talk about the anatomy. Cranial nerve 6 nucleus is in the pons, and it exits the pons anteriorly, and then it travels up along in the meninges, basically along the meninges and along the clivus. The clivus is a bone in front of the brainstem, and goes up the clivus and then makes a right angle into the cavernous sinus before it enters the orbit to innervate the lateral rectus muscle. So let's talk about the anatomic reasons why it's so common. Because it turns at an angle, a sharp angle into the cavernous sinus, head trauma, in which you have acceleration, deceleration, can stretch the cranial nerve 6 at that point and cause dysfunction. Because it runs along the bony clivus, no other cranial nerve runs along bone for so long, increased intracranial pressure will squash, compress cranial nerve 6 against the bony clivus and cause dysfunction. And then, like all cranial nerves, no different from all cranial nerves and nerve roots, frankly, chronic inflammation of the meninges, chronic meningitis, can cause dysfunction of cranial nerves and nerve roots. So, like all cranial nerves and nerve roots, it can be affected by meningitis, but it has these unique features of being prone to head trauma, dysfunction due to head trauma, and dysfunction due to increased intracranial pressure. Another relatively common cranial nerve palsy is cranial nerve 3 palsy, oculomotor nerve palsy. And the two main etiologies of cranial nerve 3 palsy are infarction and compression. Now, to understand how to differentiate those two clinically, one must understand the anatomy. Within cranial nerve 3, the oculomotor component, the component that moves the eyeball muscles and the eyelid, run separately from the parasympathetic component, that starts in the Edinger-Westphal nucleus specifically. The parasympathetic axons run outside, like a cap, outside the oculomotor nerve, and have a very different arterial supply. So in general, infarction of cranial nerve 3 results in oculomotor palsy without involving the pupil. So the patient has vertical diplopia, ophthalmoplegia, and the eye looks down and out. And there's ptosis, but the pupil is normal, both in size and reaction to light. The most common cause of infarction of cranial nerve 3 is diabetes, a diabetic third it is called. Diabetic third spares the pupil. CN3 infarctions spare the pupil. On the other hand, compression of cranial nerve 3 results in compression of both components. The oculomotor palsy occurs with the vertical diplopia, ophthalmoplegia, and eye looking down and out, and ptosis, but also the pupil is enlarged, mydriasis, and non-reactive, enlarged non-reactive pupil. The most common reason for that is posterior communicating artery aneurysm, a PCOM aneurysm, that compresses both. And of course, this also occurs in cerebral herniation, which we'll talk about at a later time in these presentations. Thank you for viewing and listening to this presentation. This is a DLG Insight production, innovative neuroscience ideas and thoughts on education.